everywhere, the bleeding history taking is very, very important. History taking and few physical examination, and of course, the battery of investigations ultimately lead to the diagnosis of these patients. The actually history, I tell, 80% of correct diagnosis can be made by history taking and physical examination. Trickling of blood, slow, prolonged, sustained bleeding, and you can counsel patient also. It won't gush, so you can counsel him also to some extent. And profuse bleeding, again, the vascular disorder or platelet disorder. Peripheral smear examination is single most important the diagnostic tool, which will tell many things, many things. That's why peripheral smear examination is very crucial. Van Willebrand's is another common congenital bleeding disorder that you have to consider.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Thank you, Medflix, for giving this opportunity. And it is opportunity to update the knowledge about the diagnosis of bleeding disorders, especially the general practitioners, clinicians, and of course our laboratory specialists. So the diagnosis of bleeding disorder so includes the, the clinical aspects and all those. But before that, I would like to just to brush up your knowledge about the normal hemostasis, which constitutes four pillars: that is vascular phase, platelet phase, coagulation phase, and the last one, fibrinolytic phase. Once the purpose is served, the vascular phase constitutes the vasoconstriction when there is an immediate injury, but unfortunately, it won't help much. But by that time, the platelets get information and they rush and form a platelet plug we call primary hemostatic plug. But unfortunately, this also is very smooth, friable, and it can be peeled off very easily from the major injuries or the major site where the blood flow is forceful. So, to make the primary hemostatic plug very stable, we need coagulation phase. Coagulation phase includes the culmination, the activation of 13 clotting proteins, and ultimately resulting in the formation of a strong fibrin which will reinforce this primary hemostatic plug so that the bleeding is stopped completely. And this happens within 4 5 minutes and makes the person easy. And the last one, fibrinolytic phase, once the bleeding is stopped, the debris formed as a result of this will be removed by the fibrinolytic phase, which usually protein C, protein S, and antithrombin 3. And in hemophilia or any of the vascular phase, for example, simple our scurvy is the one, and platelets, all of you are aware, the quantitative as well as qualitative disorders can result in poor formation of primary hemostatic plug. And the coagulation phase mainly involves the deficiency of these clotting protein, ultimately leading to the failure in the formation of the strong fibrin. So that's why the patient bleeds continuously. So with this background of normal hemostasis, let us look at how to diagnose a patient with bleeding disorder, a suspected bleeding disorder. So as everywhere, the bleeding history taking is very, very important. History taking and few physical examination, and of course the battery of investigations ultimately lead to the diagnosis of these patients. The the actually history, as I tell, 80% of correct diagnosis can be made by history taking and physical examination. 80%. So that's why our postgraduates or interns, they should be trained in taking a proper clinical history and and correlate with the bleeding and age of onset. For example, one by one I will take up the age of onset. So, if the onset of bleeding is early or during birth or childhood, so most of these disorders are due to inherited disorders. Whereas if the bleeding disorder occurs in the later age group, the most of the acquired disorders you can suspect. The type of bleeding also will tell you the underlying pathology. What is that? For example, there is a superficial bleeding and profuse bleeding and free flow of blood. So all these are due to either the primary hemostatic disorders. So whereas the deep-seated bleed like hematomas and acute hemarthrosis points towards the problem in the secondary hemostasis. So that's why even type of bleeding will determine whether it is a primary hemostatic disorder or secondary hemostatic disorder. As I told you, profuse bleeding and another very characteristic bleeding, this one. So slow, prolonged, sustained bleeding. Patient feels bleeding is stopped, but again he will rebleed. So this is a very characteristic bleeding of all our clotting disorders. Why? Because the why bleeding stops, they feel it is stopped because primary hemostatic plug has stopped the bleed. But since it is friable, it falls off easily and again he rebleeds. So that's why we can say the clotting disorders leads to trickling of blood. The best term is trickling of blood, slow, prolonged, sustained bleeding. And you can counsel patient also. It won't gush, so you can counsel him also to some extent. And profuse bleeding, again, the vascular disorder or platelet disorder, so maybe the cause. And birth history, yes, this is an indirect or direct clue, clinical clue for the diagnosis of inherited bleeding disorder. Especially the neonatologist or pediatrician, when the newborn starts bleeding from the umbilical stump, they think it is vitamin K. They give vitamin K, but bleeding still doesn't stop. Then you have to consider the two inherited bleeding disorder, fibrinogen deficiency or factor 13 deficiency. So then in the lab, you can differentiate them. Then the past history, that is, the patient suffers repeatedly, past history of bleeding episodes. Will tell you the patient has got some inherited bleeding disorder, incurable disorder. So that's why it is is getting repeated bleeding. And post surgery bleed, especially the post circumcision or post tooth extraction bleed, are also these type of bleed suggests that it could be mild to moderate disorder, mild to moderate disorder. So on treatment history, you take history. While taking history, the patient, you ask the patient how the previous bleeding episode was stopped. So he says either he has received transfusion, either he has received FFP, cryo, or platelets, whatever. So that previous treatment history also gives a clue. Repeated history, repeated transfusions, repeated injections of certain factor concentrates. So that gives the confirmation that patient may be having some inherited bleeding disorder. The drugs is very important. There are certain drugs which causes problem in the hemostasis. So especially aspirin. Aspirin interferes with the platelet function. Platelet function. That's why the aspirin injection, patient who is on continuous aspirin due to maybe IHD. So if you don't take this history, the bleeding time also is prolonged and platelets are also affected. And after the surgery, patient starts bleeding profusely on OT table. So that's why aspirin injection has to be ruled out, and you inquire whether patient is on any anticoagulant. Okay. The menstrual history, the puberty menorrhagia, especially menstrual history. how long bleeding, and in females, menstrual history is very, very important. And before going to the family history, especially the menstrual history, nowadays we have the ISTH bleeding score, clinical course score, that you can download from the WFH the website, and there are set of questionnaire, and you can score the bleeding episode, bleeding clinical core or bad score we call bleeding assessment tool. There are so many available in the website, and you can follow that. And family history, that is family, is there anybody else affected in the family, whether patient is born to consanguineous couple, whether patient the mother has got any continuous abortions, pregnancy loss, or any previous fetal death. So all these will suggest either genetic disorder, and especially the continuous pregnancy loss indicates patient may be having either factor 13 or fibrinogen deficiency. So it's a very important history we need to take. And also, it is better to write a family pedigree, because that will tell you the mode of inheritance, like X-linked recessive inheritance, hemophilia, A or B, and autosomal dominant Van Willebrand's disease, or autosomal recessive. So, mode of inheritance also you should note down in your history. Yes, now coming to the on examination, physical examination. So, physical examination, these are the lesions of bleeding disorders. The petechial lesions pinpoint less than 2 millimeter, or purpura, whether it is purpura, whether it is ecchymosis, more than 1 centimeter, little deeper, subcutaneous tissue is involved. So, ecchymotic patches. So, these lesions will tell you certain diagnosis. For example, petechial hemorrhages. Petechial hemorrhages that is seen in ITP, and petechial hemorrhages seen in scurvy has to be differentiated. So ITP or platelet disorder, ITP is widespread. Whereas if it is due to scurvy, no, it is around the hair follicle, perifollicular and painful pinhead-sized hemorrhages will suggest scurvy. Okay, so these are certain things we need to keep in mind while examining the patient. So then the slow, as I already told, slow, prolonged, sustained bleeding, yes, is a characteristic of coagulation disorder, especially hemophilia. So the deep-seated bleed, this child has got a elbow bleed, this patient has got a cut, and it is slow, prolonged, sustained bleeding, suggestive of coagulation. And as I told you, most of the coagulation disorders will have the deep seated bleed. It may be in the joint, it may be in the muscle, iliopsoas muscle, such a big hematoma, or it may even the intracerebral bleed. So, deep seated bleed, remember, clotting disorder, whereas superficial, profuse bleed are due to primary hemostatic disorders. And now, with this background, clinical history, and certain clinical examination, so now let us move on to how to how do you plan for the investigation. Okay, so now you have made whether it is a primary hemostatic disorder or secondary hemostatic disorder, whether it is factor 13 or fibrinogen, whether hemophilia, Van Willebrand's, all these you have made out. Now let us see the laboratory aspects. So laboratory aspect, let us discuss this under two heading. Screening test. Okay, these are screening tests like platelet count, and the morphology of the platelets in the peripheral blood smear, and bleeding time. Bleeding time, if at all you want to do bleeding, prefer modified IVs method, and plasma clotting test. PT, APTT, thrombin time, and factor 13 screening test, I will tell you later, and FDP, D-dimer assay. These are some screening tests you need to consider in the initial phase. Okay, definitive tests, yes, if platelet count is absolutely normal, and they are not seen in clumping nature in the peripheral blood smear, then you have to go for platelet function test, especially the platelet aggregation test with agonist and ristocetin. Then the any clotting type, PT, APTT, TT, any of these, either isolated or all the clotting tests, they are prolonged, then you have to do some correction studies to pinpoint the factor deficiency. Then once you pinpoint which factor deficiency patient has got, then you can go for particular factor assay, because you need to categorize them depending upon the level of the factor, mild, moderate, severe. Then one more test we have in the profile, the inhibitor screening test, especially those patients, hemophilia patients, who are who are receiving factor concentrates regularly, they are at risk of developing antibodies or inhibitors, we call. So that's a screening test also. If patient is known hemophilic, you have to include. And test for fibrinolysis and family studies, molecular and genetic studies are also may be needed for further confirmation or further evaluation. Now let us see certain, because I will not go into the details because mixed audience is there, clinicians as well as laboratory. So, but certain points, certain guidelines are there. You need to follow, clinicians, how to send the sample, in which anticoagulant, what proportion. So these are the things you need to know for the appropriate diagnosis. Check if patient is on aspirin. This we have already discussed. If patient has received blood and blood components or even factor concentrates, you document it. You document it, and especially those patients who needs complete coagulation workup. Keeping this point in mind, you need to interpret these tests. Okay. Otherwise, if it is not emergency, you can schedule. You can give appointment after 3 months after having received blood and blood components. Yes. How do you collect the sample collection? Yes, this is very, very important. Careful, gentle, and immediate venipuncture is necessary, because even especially neonates or children, it is very difficult. If you cause lot of stasis, lot of with vein, so there will be damage, tissue injury, and the tissue fluid will be mixed, and that will cause problem in the plasma clotting test. Okay, that's why it should be gentle, it should be immediate collection. You use either butterfly or expert nurse, you can ask to collect the blood sample. Then what is the anticoagulant of choice? That is 3.2% sodium citrate is needed, and it should be in 1:9 proportion is crucial. If you don't maintain this, you cannot expect exact appropriate results. Okay. Test should be done at the earliest, because these are all proteins. These are all proteins, and you cannot take lot of time after collection of the blood. Once it is drawn into the anticoagulated blood, it should be done maximum within 4 hours. Within 4 hours. So as far as possible, do it as early as possible, but not more than 4 hours, because there are certain clotting proteins which have certain off life. Otherwise, you will be missing certain diagnosis. Then how to prepare this plasma? Once you collect this anticoagulated blood, then you have to prepare platelet poor plasma. Okay, platelet poor plasma and platelet rich plasma both can be prepared in the laboratory for appropriate tests. Okay, for all plasma clotting tests, you need platelet poor plasma. This can be obtained by high spin, that is centrifugation at least around 2500 to 3000 for another at least 10-15 minutes. High spin plasma yield platelet poor plasma. Whereas sometimes you may need platelet rich plasma for platelet aggregation. That should not be high spin, that is low spin plasma. Low spin plasma will yield platelet rich plasma. But anyhow, coagulation studies we are doing, that's why platelet poor plasma is needed. Okay. Now let us look at the what exactly you want. Yes, the lab testing for primary hemostatic integrity you are testing now. Okay, what are these? Evaluate platelet count as well as functional tests. Okay, and bleeding time still we accept in our country, because whereas in the Western countries it is replaced by platelet function analyzer, and we are working in a resource restricted country, so still we need to depend upon bleeding time, but don't do all those crude methods. You prefer modified IVs method for bleeding time. And clot retraction also will tell you the integrity of the platelets, and many times we don't do this. Clot retraction is ignored, but clot retraction, normal platelet count but poor clot retraction, then it will suggest functional platelet disorder. Don't ignore clot retraction. Okay, then peripheral blood smear, and examine peripheral blood smear after staining. Look for platelets, look for any thing. For example, thrombocytopenia of your child, but there are seen lot of blasts. Then you can make the diagnosis acute leukemia causing gum bleeding or and all those. So that's why peripheral smear examination is single most important the diagnostic tool, which will tell many things. That's why peripheral smear examination is very crucial. Then platelet aggregometry, your aggregometry, especially the platelet function disorder, has to be diagnosed. Okay, so now let's in CBC, yes, the normal platelet count and if it is 1 lakh below, so bleeding is unlikely. Whereas if bleeding occurs, if it goes below 50,000, they are potential candidates for the bleeding. But platelet count, if it goes below 20,000, they are at risk of having spontaneous bleeding, even including even CNS bleeding. So that's why platelet count also will tell you the risk of bleeding, so that you can take appropriate measures. Okay, and also one more caution is the most of the if you are evaluating a suspected bleeding patient, don't use EDTA sample, because it will cause the clumping, and even it can cause pseudo thrombocytopenia. Pseudo finger prick smears are preferred rather than anticoagulated blood if patient is suspected bleeding disorder patient. Okay, assess platelet morphology. All of you are aware platelets are seen like a pinhead size particle seen in clumps. Pinhead size particle seen in clumps. So if pinhead size is almost competing with the RBC size, then it is a pathology. Okay, so that's why the platelet distribution in the peripheral smear also is important to note. Yeah, this is just bleeding time. Bleeding time, you can see this is modified IVs method, and you tie the BP cuff. Okay, maintain the BP, that is blood pressure, 40 millimeter of mercury throughout the test. Throughout the test, and also you take lancet, whether even lancets are there or some programmed lancets are there. So use them, and you instantaneously, like you can make 3 successive incisions and start blotting the bleeding till the bleeding stops. So this will give the bleeding time. Bleeding time will tell you the integrous platelet count, either thrombocytopenia or thrombocythemia. So clot retraction also will help. So these 4 simple basic investigation anywhere we can do will tell the diagnosis without any much problem. Okay, now you can see here thrombocytopenia only 1 clump, and you can see, whereas here, as I told you, pseudothrombocytopenia, they are all clumped platelets because of the EDTA. Then clot retraction, as I mentioned, after the formation of blood clot, the separation of the serum. the amount of serum separated will tell you the clot retraction. Okay, so this is called clot retraction. So you can keep for 30 to 45 minutes or 1 hour. You will see the amount of serum separated. You measure it and express it in percentage. Okay, so now absolutely normal platelet count 4 lakhs, 5 lakhs, but clot retraction, not even 1 drop of serum is expressed. Then that is more than enough to make the diagnosis of functional platelet disorder. Okay. So then the platelet thrombocytopenia, how to evaluate again if patient has got thrombocytopenia? Yes, yeah, you just some family history, whether especially children, like the bone marrow failure syndrome, so many rare genetic disorders may be there. Carefully review medications as we have already discussed these. Okay, especially the phenytoin, anti-epileptic drug, okay, anti-malarial drug, certain antibiotics. So they can cause the interfere with the platelets. And ask about condition in which associated with low platelet count, maybe liver disease, cirrhosis patient, or a patient with hepatitis and thyroid autoimmune or any hypo or hyperthyroidism, infections, especially viral or rickettsial virus infection can lead to thrombocytopenia, and pregnancy. Okay, consider other conditions which may be associated with ITP. Okay, ITP also you have to rule out. Then the autoimmune disorders like lupus erythematosus, the CLL. Okay, CLL, especially the Ivan syndrome. Okay, lymphoma, antiphospholipid syndrome. All these has to be considered and rule out before making the diagnosis. And again the low platelet count, look for any lymphadenopathy or any splenomegaly, massive splenomegaly, sequestration of platelets. That may be the reason for thrombocytopenia. And lymphadenopathy, generalized lymphadenopathy, ALL in children, that may be the cause for thrombocytopenia. Okay, look for signs of bleeding, gum bleeding, and all those, and blood blisters and oral petechiae, we call wet purpura. So these has to be noted, and the laboratory data also, if earlier it is done, or the blood count should be normal, and check for beta folic acid, because one of the most common in children, this is the what you call the vitamin beta folic acid, that is megaloblastic anemia, may be the first manifestation of bleeding manifestation may be there. That is because of the thrombocytopenia, that is due to dyshematopoiesis, and patient have thrombocytopenia, that is because of beta folic acid. It is a treatable cause. Okay, look at peripheral smear to exclude pseudothrombosis. I already told, exclude ITP. Okay, TTP also, thrombotic thrombocytopenic purpura, and especially with CNS manifestation. Send coagulation screens like PT, APTT to exclude DIC. Send HIV, hepatitis serology and TSH, and H. pylori antigen in stools, breath urea test. Consider doing a bone marrow biopsy or bone marrow aspiration. Okay, so to rule out in our setup ITP, and obligatory in patients, especially those who are elderly people. Elderly people prefer bone marrow just to rule out MDS or even leukemia or lymphoma, and megakaryocytes should be whether they are present or not. So these are the conditions you need to keep in mind. Now let us look at here. So here the platelet is absolutely normal. Bleeding time is prolonged and clot retraction is poor. No aggregates or clumps in the peripheral blood smear, and platelet aggregation will tell you, they will show you platelets do not aggregate with all aggregating agents, but they aggregate only with ristocetin. What is the diagnosis? Glanzmann's thrombocythemia. So Glanzmann's thrombocythemia is very easy to diagnose in our setup. If patient is poor, at least the poor normal platelet count, a poor clot retraction, and no aggregates in the peripheral smear, definitely it has to be glandular thrombosthenia if patient is affordable as per platelet aggregation. Then you can see here this in contrast to glandular thrombosthenia, both are functional platelet disorder. Here you can see mild to moderate thrombocytopenia and clot retraction is variable depending upon the platelet count, and but in the peripheral smear you will see giant forms of platelets, and in the platelet aggregometry the abnormal platelet count aggregation with ristocetin. Then what is the diagnosis? Bernard-Schauer syndrome. Bernard-Schauer syndrome. So mild to moderate thrombocytopenia, poor clot retraction, and giant forms of platelets in the peripheral smear. You can make the diagnosis Bernard-Schauer. If patient is affordable, you can ask for the platelet aggregation studies. Then now let us go to the secondary hemostasis. In secondary hemostasis, what are that is we have to evaluate the efficiency or the presence of clotting protein or deficiency of clotting protein, and detection of inhibitor also is our responsibility. And generally the screening tests are prothrombin time, activated partial thromboplastin time, and fibrinogen and thrombin time. So now these are the three tests we need to do. You can see how do you interpret these plasma clotting tests? Yes, there are situations where only PT is prolonged, isolated prolongation of PT. Then if once you rule out the liver pathology, you can think of, especially in children, factor 7 deficiency or oral anticoagulant therapy. So isolated prolongation of PT, these are the diagnoses. Whereas isolated prolongation of APTT, yes, it could be factor 8 deficiency, it could be factor 9 deficiency, or it could be factor 11 deficiency. That means hemophilia A, hemophilia B, and hemophilia C, which can result in isolated prolongation of APTT, and also very rarely pre-calligrate. But Van Willebrand's is another common congenital bleeding disorder that you have to consider. I see that there also you use the clinical data. If isolated prolongation of APTT among females, the first diagnosis we think it is Van Willebrand's, whereas in males we think hemophilias. But anyhow, so you have to evaluate further. And one more condition where isolated prolongation of APTT is seen, that is inhibitors. That is a lupus anticoagulant is the most common anticoagulant we encounter in our clinical practice. So now let us see the prolonged PT and APTT. So PT, APTT both are prolonged. Then you have to consider factor 5, 10 and 2 and oral anticoagulants and vitamin K deficiency, liver disease. Okay, and prolonged all the three clotting tests, all the three prothrombin time, APTT, TT are prolonged. So then what would be the diagnosis? Fibrinogen deficiency. Fibrinogen is we call unclottable blood. Clot won't occur at all, and ESR will be 0 in these patients. And you can take these clues. Okay, if all the three, see, the common clinical manifestation is prolonged bleeding from the umbilical stump. But in the lab, if all the three plasma clotting tests are prolonged, then it has to be fibrinogen deficiency. In contrast to this, if all the plasma clotting tests are absolutely normal, it is not fibrinogen deficiency, we have to consider factor 13 deficiency. Then you have to look for the fibrin stabilizing factor, that is factor 13, and by tests like 5 molar screening test in our setup, we can do screening test, and if facility is available, you can also do factor 13 assay. If all the three are prolonged but umbilical stump bleeding is there, then prolonged bleeding time or abnormal PFA, yes, platelet function test. Platelet, it may be Glanman's, it may be Bernard-Schauer, or one more among the female, most common Van Willebrand's disease. So prolonged APTT and prolonged bleeding time, diagnosis has to be Van Willebrand's, not hemophilia. Okay. So prolonged APTT and normal bleeding time and cross. Even purposefully, I am avoiding clotting time. Here only I would like to emphasize on discouraging the clotting time. BTCT concept has to go, because in mild to moderate clotting factor deficiency patients, the clotting time will be absolutely normal. Absolutely normal. Believing this, surgeon, if you allow surgeon to put a knife on the patient, then you will face the music on OT table. So that's why the most sensitive test we need to consider for pre-operative hemostasis screening, it is not BTCT, it is PT, APTT at least. Okay, then you will never miss mild. In mild hemophilia, we have seen mild hemophilia, he never had a bleeding episode, he comes for a tonsillectomy, and now even clotting time, bleeding time is absolutely normal, but on OT table, he started bleeding profusely. So that's why please emphasize on the sensitive test for pre-operative screening tests. Okay. Now coming to mixing studies. So I have discussed isolated prolongation of PT, isolated prolongation of APTT, or all the three are prolonged, all two are prolonged. So now the next level of investigation is mixing studies. What do you mean by mixing studies? Whatever the plasma clotting test prolonged, that has to be corrected by adding normal control plasma, and see that APTT is normalized or not. Okay. If the APTT prolonged after adding normal control plasma, if it gets corrected, that means patient has got factor deficiency. Suppose if the patient's APTT is not getting corrected even after adding normal control plasma, you have confirmed he doesn't have any plasma factor deficiency. Then what else? What it could be? It is, as I told you, the lupus anticoagulant or the inhibitors. Inhibitors has to be considered. Okay. So this is very important. In mixing study, we can conclude that. So next mixing study is to determine which factor is deficient. So you can see here isolated prolongation of APTT, and it is corrected after adding normal control plasma. You have confirmed it is a plasma factor deficiency, but which factor deficiency, that has to be ascertained. For this, we prepare certain reagents in the lab. We call aged plasma, adsorbed plasma. Okay. So aged plasma is nothing but nearly 48 hours old plasma, incubated plasma. So that has to be prepared as per the guideline, and you add aged plasma. If there is no correction, then but it is corrected by adsorbed plasma. Adsorbed plasma is prepared by adding the barium sulfate or aluminum hydroxide, and certain factors are adsorbed. Okay. So if it is corrected, then the diagnosis you can release factor 8 deficiency. So factor 8 deficiency. Whereas factor 9 deficiency, you see what will happen: prolonged APTT and now corrected by normal control plasma, but the adsorbed plasma no correction, but aged plasma it is getting corrected. Aged plasma, again we are taking a clue advantage that factor 9 is a stable protein. Okay. When you compare to factor 8, we call it is a labile protein. So that's why this is the situation. Whereas stable protein, even the factor 9 half-life is more than factor 8. So it for therapeutic purpose we consider even 24 hours, whereas here it is around 8-10 hours. So that's why it is a stable protein. So you expect it to be corrected by aged plasma. Okay. Now you see APTT prolonged and controlled by normal control plasma, but now it is corrected by both, because it contains both factor 11, factor 12, factor 11, factor prolonged APTT corrected by both aged plasma and adsorbed plasma, suggest it is neither factor 8 nor factor 9, and it has to be factor 11 and factor 12. Factor 11 I told hemophilia C. And how to differentiate these two? Clinically, this factor 11 factor 12 patients will never bleed. Okay, they are all asymptomatic. Whereas factor 11 patients bleeds. You take this clue. Okay, corrected by both, but patient bleeds. The diagnosis is factor 11. Patient is no bleeding at all. So then you can consider factor 12. Okay. Then the inhibitor, as I have mentioned, it is prolonged, no correction. Why? It is not plasma factor deficiency. So that's why there is no correction. It won't get corrected with any of these. Okay. So that is called inhibitor or lupus anticoagulant. Then other like this, you can diagnose rare factor deficiency also. In a medical college setup, we can do all these tests. Okay. So factor 2, factor 5, factor 7, 10. Okay. Again, depending upon the which one, it is like a mathematics, and you can pinpoint which factor deficiency they have by noting the correction studies. Then other plasma reagents for mixing studies we use, one is normal control plasma. Only one caution is you should use pooled plasma. The 20 normal healthy people, you can take it as an exercise in the medical college department, and you can prepare your own pooled normal plasma, and you alicate it 1 ml, keep it in the deep freezer, and every day whenever you do, take that 1 ml alicate, and that will be your normal control plasma for the whole day. Okay. Then selective plasma, as I told, the what you call aged plasma, adsorbed plasma, you can make the diagnosis of either hemophilia A or hemophilia B. Patient with abnormal APTT corrects with factor 9. So sometimes it is difficult to achieve, like quality control issue are there. So that's why some of the labs, what they do, instead of doing adsorbed plasma and aged plasma, they take the known deficient plasma, that is factor 8 deficient plasma, factor 9 deficient plasma. The easy to understand, patient with abnormal APTT corrected by factor 9 plasma, what else it would be, it is factor 8. In the same way, vice versa. Okay, that's why they can pinpoint which factor deficiency. But anyhow, quality control issue, you should be careful. Yeah. Then coming to, once you pinpoint which factor deficiency, you can do factor assays. That is, factor assay principle is, it is the ability of the patient's plasma to correct a prolonged PT or APTT of a known factor deficient plasma. So normal activity will be 50 to 150%, wide range. Okay. So it determines type of factor deficiency and activity. So PT based factor assay, that is 7, 10, 5, 3 and 2. And APTT based factor assay, factor 12, 11, 9 and 8. So that's why the procedure and all those things I will skip because that So once you pinpoint which factor is, even factor assay, simple, one minute I will take. So dilute standard with known factor 8 deficient plasma, approximately 100%, and test plasma in buffer. That you make it in dilution 1 in 10, 1 in 20, 1 in 40. Mix with equal volume of severe factor 8 deficient plasma. Do APTT. Plot standard graph with correction times of standard. On the same graph plot, patient's timing. 3 points with a straight line parallel to the standard. So this, unless you do, you won't, because it is very little complex, but you can do. It is not a rocket science. So you can plot the points of APTT and draw the line, the patient's plasma and reference plasma, and wherever it intercept, no, then you can draw a line, and that is your factor 8 assay, factor 8 level. Okay, that's why we need to do factor less than 1% patient who bleeds spontaneously, who bleeds repeatedly, whereas moderate patient more than 1% and 5%, they bleed, spontaneous bleeds may not be so much, but they bleed on trauma, and mild category of patient more than 5% and 50%. So these are all mild. According to me, these are all dangerous people because they may not have bleeding in their lifetime, but when they are subjected for any major surgery or any even minor surgery, the bleeding doesn't stop, or any road traffic accident, bleeding doesn't stop. Okay, so now coming to one more common disease we encounter, Van Willebrand. This is little complex to diagnose, but anyhow, you can make the diagnosis. As I told you, in general, the prolonged bleeding time, prolonged APTT. Okay, so you can make the diagnosis of Van Willebrands, but there are certain tests, profile of investigation you have to do. The basic test you have to do, yes, APTT is prolonged, and VWF antigen assay. VWF antigen assay nowadays we can do. Even LSA kits are also available, and also the ratio, that is Van Willebrand factor and ristocetin cofactor assay. So that this also we can do, and factor 8 assay also you have to do, because the Van Willebrand disease can be classified broadly into quantitative, qualitative. Quantitative further mild disorder, and severe disorder. Severe disorder where factor 8 levels are also markedly reduced. That will give you the clue. If factor 8 also is markedly reduced or at least moderate level, you can consider type 3. Okay, and multimer assay in our setup it is difficult. We cannot do this. But there are this ristocetin induced platelet aggregation test. That is low dose or collagen binding, and the VWF factor 8 binding, okay, 2N to diagnose. So these are subtypes of Van Willebrands. As I told you, quantitative, qualitative. Quantitative is mild is type 1 and severe is type 3. Whereas qualitative is little difficult to diagnose. But here there are again, I will give you some indirect clues. That is in type 2A, type 2B, type 2M, type 2N. Type 2N, as I told you, VWF and factor 8 binding is defective. Okay. So, and one more, type 2B goes with thrombocytopenia. If thrombocytopenia in a known Van Willebrand disease patient, rule out type 2B. Okay. So, and also these are rarely occurs VWF antibodies and platelet Van Willebrand factor, and these are all very difficult DNA and study and all. If patient is affordable, you can refer them to higher centers. Then inhibitor screen. As I told you, APTT is prolonged. If it is not getting corrected by normal control plasma, then you have to consider there could be some inhibitors. Okay, whether it is PT or APTT. So you have to consider auto antibody, that is lupus anticoagulant, SLE or Jogren. All those things can give rise to these auto antibodies. Then here you can see immediate PT or APTT. You mix with off patient off control. If the correction is there, then it has to be factor deficiency. Only lupus like anticoagulant comes into picture if there is no correction of the prolonged APTT with normal control plasma. Okay, here I would like to also mention about the inhibitors formed in the non-hemophilic who are receiving factor 8. But these inhibitors are time-dependent inhibitors. So that's why you have to incubate it for 2 hours. And if there is correction, if there is correction or no correction, you have to consider. Okay. So if there is no correction after 2 hours, then it concludes patient has developed antibodies against the factor 8. Yes. So again, if patient inhibitor screening test comes positive, no correction after 2 hours, then you have to do one more test further to classify the inhibitors or quantify the inhibitors for therapeutic purpose. Okay. Those patients who are having 5 Bethesda in it, more than 5 Bethesda or less than 5 Bethesda. Why it is important? Those patients who gives less than 5 Bethesda, still factor 8 has got a role in the treatment. Only thing is, modification here is you have to give in double dose or triple dose. Okay, high dose of factor 8 all works with low titer inhibitor that is less than 5 Bethesda in it. Whereas those who are more than 5 Bethesda in it, any amount of doubling or tripling, it will never help. Instantaneously, the antibodies will kill the factor 8. That's why there is no role for factor 8 concentrates in high titer inhibitors. So then you have to go for the bypassing agents. Okay. For this decision, you have to do Bethesda or Nijman's method or Bethesda method of quantification of the inhibitors. Okay. So now let us see. We have discussed isolated prolongation and different scenario. Now you see there is a scenario like bleeding disorders with absolutely normal PT APTT. Then as I repeatedly mentioned, factor 13 has to be considered, especially if the patient has got the umbilical stump bleeding. For this, how to confirm this? In our setup, resource restricted, we can do 5 molar urea clot solubility test. Okay. And factor 13, all of you know that it is popularly known as fibrin stabilizing factor. Fibrin stabilizing factor. And it plays a role in stabilizing the clot. That is, the monomeric fibrinogen can be converted into polymeric only when there is factor 13. So that's why if there is no factor 13, monomeric remains monomeric. That's why patient bleeds. And the wound healing also is delayed. That is one. And one more point I would like to emphasize here is these patients' family, as I told you, take detailed clinical history, especially series of pregnancy loss. You just look at them. At least two, 3 pregnancy loss, abortion, stillbirth, history will be there. Why this kind of history is there? Because it is not only fibrin stabilizing factor, because factor 13 will help in implantation of the fertilized ovum. In absence of factor 13, this fertilized ovum implantation doesn't occur. It slips. That's why patient gets repeated pregnancy loss. Then dysfibrinogenemia, again, in liver function test you have to ask for. And these are all rare. That is mild isolated factor deficiency, alpha 2 antitrypsin, antiplasmin deficiency, and elevated FDP, and platelet disorder, vascular disorder, where your plasma clotting test may come normal. So that's why history taking and selecting the appropriate investigation is crucial. Yes, the last one, don't forget factor 14 deficiency. 14 deficiency. Is there 14 deficiency? I would like to call this as local pathology. Okay, don't think of all these disorders. You can also think of the local pathology. Once during my post graduation, they called one patient after post-operative bleeding. Okay, there we noticed they have left one capillary, one blood vessel spurt. It was spurting from the local pathology. So that's why don't ignore local pathology also. Maybe infection, maybe insufficient suturing. So these also you have to consider. Okay, then yes. So that's why to summarize today's topic, because as I told you, I have not gone into the details of this thing. Maybe subsequent sessions only when we discuss about hemophilia, when we only discuss about van Willebrands, then especially for pathologists, then we can go in detail. Okay, thank you. So this history and physical examination, laboratory evaluation with screening test and specific diagnostic test and diagnosis specific therapy. Because in hemophilia, if you don't know which factor is deficient, you cannot treat him. Okay, you have to treat with the appropriate factor. No, so the laboratory evaluation is crucial in these inherited bleeding disorders. Okay, diagnosis, specific therapy, factor replacement, drugs. And nowadays, because of the advent in the technology, now we have lot of advancement in the treatment like non-factor therapy, now extended off-life factors. Okay, those things we can take during our exclusive hemophilia discussion. Okay, I must thank Medflix and Dr. Basra and Dr. Yeah. So thank for this opportunity to interact with our medical community. Thank you. Yes, one question here. How bleeding can be stopped in a patient with uh, rivaroxaban? So I think this. Uh, So actually, this is beyond my expertise, and better you ask a clinical hematologist.
So thank you for this wonderful session. Within this limited time, you beautifully covered the topic. We do have some doubts coming in from our doctors, and we will be going into the Q&A. So I'm taking one of the earlier questions that we had. It was from Dr. Patel. Sir, please explain in details about PT, APTT, TT, and also what is INR.
Actually, yeah, good question because PTFD, INR, because each laboratory varies from lab to lab, the values. So that's why the company gives you the ISI or this range. Okay, keeping that in mind, we calculate the INR. Okay, patients a PT and control PT, because by putting the IN, that is ISI value, then only you can interpret uniform.
Right, sir. So moving on to the next question. So Dr. Mishra wants to know why in CBC report platelet count is a low variable.
Yeah, this is a very nowadays we face lot of problem with cell counters, and also there are a lot of pre-analytical care you need to take. That anticoagulant, even proportion, and all those things you have to keep in mind. Okay, sometimes the platelet count with giant forms of platelets or those regenerative platelets. Sometimes the cell counter. So in such situation, so it is better to do with the manual method or look at the peripheral smear if you have any problem in the report. And also one more point I would like to share here. There are even especially the northeast area, Kolkata. So the platelet count normal range also varies. Okay, so always platelet count in some donors they have studied, always it will be in the moderate range. So after that, yes, we have to consider whether we need to re-evaluate this platelet count or not.
Taking the next question from Dr. Kulkarni, why RDP infusion should be fast?
RDP infusion should be fast. That platelet uh, random donor fast. There is no clear cut this thing. I don't whether to give fast or not. I am not aware. But anyhow, platelet concentrates, especially RDP, we have to transfuse carefully. But what is the fast and all those things, I don't have any idea.
Uh, Next question from Dr. Madhav. How alum application arrests bleeding and which factor is responsible for that?
How alum, because uh, alum, there are certain agents, for example, uh, the uh, some even recently some vegetables, no, so we don't know exactly, maybe some calcium, but this will never stop the bleed of inherited bleeding disorder patient. Okay, some the platelet or platelet disorder or any traumatic bleed, so they can stop. But inherited bleeding disorder, they don't have any role. Local hemostatic you can consider.
So next question from Dr. Carr. If INR value is more than 3, then it is not going to any type of surgery. Why is that?
Because if INR is more than 3, uh, because uh, uh, the bleeding tendency, no, may be more. That's why they don't take for surgery.
So doctor is taking in the last question for tonight. It is from Dr. Shah. Why intubation is required in mixing studies for inhibitor?
Because inhibitors, I can tell that there are different types of inhibitors, whereas auto antibodies, as you see in the SLE or lupus anticoagulant, they are immediate acting antibodies. They are immediate acting antibodies, whereas the antibodies which are developed in non-hemophilic because of the factor infusion, they are not auto antibodies, they are allo antibodies. Okay, and have they are also known as time dependent antibodies. Okay, the factor 8 antibodies are time dependent antibodies. So that's why if you mix the patient plasma and the control plasma and immediate mix, because we cannot decide whether he doesn't have inhibitor or have inhibitor by noting immediate mix, because they are all time dependent inhibitors. After 2 hours only, if the APTT is not corrected, then only you can declare patient has got antibodies. Okay, so that is because of the nature of the antibodies. Whereas in contrast to, I told immediate acting antibodies, but the antibodies developed among known factor 9 deficient patients, they are not time dependent factors. They are not time dependent. They are immediate acting antibodies as SLE and all those. So these are certain the biological behavior of the inhibitors. Based on this, we have to conduct the test.
Before we end the session, just another question from Dr. Carr. What is the safest range of INR value for any type of cardiac surgery?
Because that is generally we look to INR within 2 and so. But anyhow, as I told you, I am not a cardiothoracic surgeon or even clinical hematologist. Better you discuss with clinical hematologist.
With that, thank you, sir, for taking in our questions. With that, I would also like to mention that there's a lot of appreciative comments coming in from our doctors for the session. They
Thank
really seem to love it. And thank you once again for doing this session with us. Really hope to see more of you on Medflix, sir.
thank
Thank
you.
you once again, sir.
Thank you very much. Good night, everybody. And I thank all of you. If there are any some more questions, you can write to me, or you can mail, or yeah, whatever the mode. And thanks once again, the Netflix, Bethesda, the team. Okay. Thank you. Thank you very much. Good night.
Thank you, sir.